just to give importance, so Sharad will announce when to start.
1 minute to go.
Yeah. That's why I said Sharad will announce.
टाइम कैसे रखेंगे इसको?
ऑटो टाइमर है ना आप लोगों का? बस ठीक है. कितना मिनट दे रहे हैं इनको? 4 minutes पर प्रेजेंटेशन. उसके बाद निकाल देंगे? नहीं क्या भैबू बजाएंगे कुछ? ठीक. कोलकाता एली एक बांग्ला चले रखो, सब बांग्ला बजा. Aditya meets me elsewhere also, but he doesn't see me in this.
Start.
I start. Good afternoon. Today I'll be talking about the prevalence of
timing rakho, sorry. Shuru korechi.
I'll be talking about prevalence of bacillary layer detachment in diabetic macular edema and the response to anti-VEGF. So there are no financial disclosures. Bacillary layer consists of both the inner and the outer segment of the photoreceptor cells. The inner segments of the photoreceptors contain ellipsoid and the myoid zone on OCT. In 2018, Mehta et al. Introduced a new OCT-based terminology called bacillary layer detachment. So in this detachment, the bacillary layer is attached to the retinal pigment epithelium, whereas the remaining fragments of the split myoids, the external limiting membrane, as well as the anterior retinal structures detach and move anteriorly. So there are two main factors responsible for this: potential loose space within the photoreceptors and the hydrostatic force from the choroid. The aim is to determine the prevalence of bacillary layer detachment in diabetic macular edema and its clinical response to treatment with intravitreal injection of anti-VEGF. It was a hospital-based prospective observational study done among 33 patients of diabetic macular edema who underwent a treatment with 1 dose of intravitreal injection, followed up for 2 months and then treated on PRN basis. All eyes were divided into 3 groups. The SRF only group had SRF but no Ballard, and the Ballard group had both SRF and Ballard, and the group that had neither SRF or Ballard. The results: 33 eyes of the 28 patients presenting with DME were included. Mean age was 59 years. Mean BCVA was 1.06 logMAR. Mean CMT was 898. These are some of the pictures showing the features of SRF with Ballard in DME before treatment and the OCT of after treatment, or 2 months after treatment. And this is the OCT showing features of SRF only in DME before treatment of the same eye 2 months after treatment. So the total distribution of patients based on the OCT finding: 51% had only SRF, only 10% had SRF with Ballard. The results: a significant increase in the baseline CMT in the SRF group was observed versus SRF with Ballard versus no SRF or Ballard. So the eyes with Ballard tended to have the worst baseline visual acuity and showed the least improvement after treatment. Ballard was present in 9% of eyes presenting with DME along with SRF. Only SRF was present in 51%, and neither SRF nor Ballard was present in 39%. Total resolution of Ballard was noted after anti-VEGF, along with a significant decrease in CMT in both SRF only group and no SRF Ballard group. But slight increase in mean CMT in Ballard group was observed, which was not statistically significant. The mechanism is yet to be determined. According to Kohli et al., inflammatory, infiltrative, or ischemic conditions of choroid reduce the perfusion of the outer retinal layers and RPE, altering the balance in the retina, resulting in splitting of ellipsoid zone and the myoid zone. So according to Chang et al., with anti-VEGF therapy, total resolution of Ballard and a significant decrease in CFT can be obtained and showed the most improvement in BCVA. But our study suggests that even after resolution of Ballard and slight decrease in CMT showed worse visual outcome after treatment. So to conclude, our study suggests that Ballard was observed in 9% of the eyes presenting with DME and showed poor outcome functionally and structurally after treatment with injection anti-VEGF. The limitation of our study includes failure to consider central foveal perfusion parameters to account for the choroidal ischemic component and the exclusion of choroidal thickness measurement, which may play a role in the pathogenesis of Ballard in DME. Further studies with larger sample size and wider inclusion of parameters to measure the perfusion and the choroid is required to ascertain the reliability of Ballard as a significant biomarker. These are my references. Thank you.
So, so nice concepts. How long was the follow-up?
3 months, sir.
3 months.
3 months.
Do you think it's long enough to consider?
It has to be longer, 6
Okay,
months.
because as it is Ballard is sorry, not specific to DME only, but across
Yes,
many inflammatory disorders, infiltrative, as you know.
Yes, sir.
So, of course, few OCT pictures didn't typically showed Ballard with the.
Ballard. Yes, so there were 3 groups with only SRF group and SRF with Ballard and no SRF or Ballard.
How do you differentiate? Sometimes it confuses with the outer retinal tubulations.
Yes, sir. But with SRF only group, they did not have, like, if we look at the edges of the edema, we can make out this thing. So they will be curved, and you can actually see the splitting at the photoreceptor layer. But in SRF only group, that splitting will
What
not be
was the
able to,
OCT that you
irregularities
used?
will be there.
Swept source?
Sir?
The OCT was swept source?
No, SD OCT.
SD, spectral tube.
Yes, sir.
Anything to?
Like, is there any recurrence? You have followed up all the patients for 3 months.
Yes.
What is the recurrence rate of bacillary layer detachment?
Recurrence, we did not see.
Now, if it is getting subsided, then again it recurs within 3 months, or you have to do more follow-up.
Yes,
for
sir.
the
We
recurrence
need longer
yes,
follow-up
longer
to see
follow-up is
whether
necessary.
recurrence was there.
Thank you.
Basically, it is a chronic inflammatory disease, so it is very difficult to conclude in 3 months follow-up.
Yes, sir.
Absolutely.
Sometimes it is very difficult to identify Ballard in presence of exudation and edema. Did you have any difficulty in identifying them?
There were difficulty to identify it, but not in DME, sir. We've also done a study where there is Ballard in posterior uveitis, and which is also seen in weakage. So in those conditions, it was difficult to diagnose. But in DME, the cases who had Ballard, we could easily identify. With the cases who had only SRF.
But Ballard, as all of us share the same view, that it is not very specific marker, biomarker. It cuts across spectrum of many various disorders.
Yes.
So anyway, but the concept that you try to make, good effort. Please come.
Thank you.
Aditya next. AI-powered smartphone fundus camera, advancing, referable and screening.
Yeah, good afternoon.
Sorry.
So I'll be talking about in a scenario where we have an increasing aging population, the burden of AMD is going to increase further. So we need a good screening strategy. So with that in mind, the purpose of this study was to evaluate the performance of a novel AI-based device which was implanted on a portable smartphone-based fundus camera to detect its ability to pick up referable AMD. It was a single-center cross-sectional study conducted in patients over 40 years of age with suspected AMD, and the device in question was this non-mediatic Remedio fundus on phone device, as you can see here, no financial interest. So the AI algorithm was developed by training the software with using over 100,000 images obtained from the ARET study, and subsequently on a smaller set of Indian eyes it was validated. So this is the device, as you can see, it takes a non-mediatic fundus photo, and then the software runs and gives you a reading that whether it's a referable AMD or not. So the study flow was like the patients underwent the imaging by this device, and the software told whether it was referable or non-referable AMD. All these patients also underwent detailed clinical dilated fundus examination, fundus photography with Claris, and an OCT line scan. Then independently, 3 retina consultants in a blinded manner graded these images, and the combined grading using the OCT and the fundus picture was taken as the final gold standard against which the performance of the device was compared. So this was the ARETS classification that we used, no AMD, early, intermediate and advanced AMD. The intermediate and advanced AMD were considered as referable AMD, and the earlier categories were considered as non-referable. And combining both the OCT and the fundus imaging, the consensus grading of final AMD grading was arrived at using the same ARETS nomenclature. So as you can see in the results, we had around 490 patients with a mean age of 62, and in the total of 256 referable AMDs, the software correctly identified 233 of them. What is more impressive was in the advanced AMD category, 171 out of 178 referable AMDs were picked up, which is like nearly more than 96%. And there was a good inter-grader agreement between the 3 graders, especially when using combined grading compared to when using fundus grading alone. So, and among the false positives, among 233 non-referable AMD cases, about 34 were falsely flagged as referable, but most of them had early AMD compared to no AMD. So, as you can see, the sensitivity and specificity of the device was 90% and 85% respectively, with the overall diagnostic accuracy of 88%. The majority of false negatives were intermediate AMD, and very few advanced AMDs were missed, and majority of false positives were at least early AMD, and very few non-AMDs were referred as true AMD, referable AMDs. So these are some of the examples of the images. You can see some true positives where a CNVM and an intermediate AMD was correctly identified, some false positives where a no AMD or an early AMD was falsely flagged, true negatives, and a false negative here where you can see some intermediate AMD being missed by the device. So to discussion, the diagnostic accuracy of this software was similar to other AMD algorithms reported in literature, and the strength of this study was it was a prospective study on a large number of cases, and it is an offline AI which can be integrated into a smartphone based fundus camera, and the next step would be to validate it in a more widespread population based scenario where we get the true idea of prevalence and the screening. So to conclude, it is a novel offline AI integrated on a smartphone fundus camera, and it has a potential to make AMD screening accessible, affordable, and effective for all. Thank you.
How much was the sensitivity in the early AMD group?
Sir, so the device was trained only to pick up referable versus non-referable. But if you ask me, overall its ability to pick up any AMD was about 84%.
Because according to your data, a lot of findings are missed in the early and intermediate.
Yeah.
They are the patients who require early referral and treatment. Advanced AMD anyway, I think.
So referable AMD was classified as intermediate or advanced. So it's only early and no AMD cases which were non-referable. Intermediate and advanced were referable.
Who's the company who does
Remedio, sir, Remedio.
No, software, AI software.
So they have only collaborated and with the US company, and they have developed the software.
Because I saw a large number of IRATs.
Yes. So we took permission from them, and we analyzed they analyzed the images with trained the software. Then they analyzed in different centers in Bangalore and others on Indian patients. And once it was validated, then the study came to our center where we tested it with the gold standard of 3 retina consultants to validate whether this applies to our patients or not. So we did the last part of the study. The initial part was already done by the company, and
this study assumes importance in view of the fact that all our efforts are directed towards DR screening.
Yes, sir.
If this can be combined with AMD screening, as
yes.
we are doing since a long time.
And it's a portable, non-mediatic device, and it's offline AI, sir. So it does not need internet connectivity. Once it's deployed, it can be used.
Thank you.
Thank you, sir.
Next.
Malvika Mujumdar.
My study is a random forest classifier based approach in the detection of abnormalities in the retina.
মাইকটাই কাছে করো ভাই, মাইকটা নিচে করে দাও। হ্যাঁ, রাহুল গান্ধী যেরকম করে।
It is a commonly used machine learning algorithm trademarked by Leo Brayman and Adil Cutler, which combines the output of multiple decision trees to reach the single output result. It has a bagging and out-of-the-bag ensemble method. This is a cross-sectional and prospective study to detect and classify the abnormalities of retinal diseases at an early stage using image processing and machine learning. Here, a comparison between random forest and naive Bayes classifier is done. 405 images are used to form a retinal image dataset from publicly available databases having different signs of diabetic retinopathy and AMD along with the ground truth. Step 1 is image pre-processing, where colored retinal images are converted to grayscale image. Gamma correction is done on the image to adjust the contrast of the image. Value of gamma is chosen for bright lesion detection, and for dark lesion detection, value of gamma is selected as 0.5. K-means clustering is a partitional clustering approach which groups data objects depending on their similarity. It performs image segmentation. Here we try to club similar pixels in the image together. 3 clusters are derived: bright yellow, dark red, and yellowish red. These three clusters get different color in each run of the segmentation algorithm. But the spatial value of brightest point and the darkest point helps to resolve the problem. So now for the optic disc elimination, extraction of cluster corresponding to bright color like optic disc and bright lesions are done. Then image opening to eliminate the structural element of disc type radius 5 done. Now the image 2 is subtracted from the image 1, which leaves only the lesions. And this similar kind of thing is done with the blood vessel elimination, and in that the disc type 2 is applied. So feature of abnormal objects which are to be detected are appearance-based features and region-based features. Appearance-based features are 4: color, shape, size, and sharpness of the edge. Whereas the region-based features are area, perimeter, eccentricity, convex area, solidity, circularity, compactness, standard deviation, smoothness, and Euler's number. So now the random forest classifier is applied, where there are 440 training set and 227 are testing set. Bootstrap sampling is done, and for each bootstrap sample, one decision tree is drawn, where only one outcome comes, and the final outcome is based from the majority voting. And for the result, the feature vector for each input retina contains 14 features with a disease name as its class. The image processing done, and the feature vector is evaluated for each image from its corresponding output image. Next, the performance analysis is classifier is Weka determining tool is applied. For discussion, random forest classifier decision tree approaches are similar to the physician's approach. It has high accuracy with large number of training data set, and the feature vector during learning makes it robust and efficient classifier. For conclusion, random forest classifier results are in good agreement with diagnosis of an eye specialist, and the performance analysis of random forest classifier is significantly high compared to naive Bayes classifier. Thank you.
Like the conclusion last second statement, whatever you have made, that how can we say that that classification is better than the
Yes, sir.
until and unless you are doing the two comparatives?
Yes, we have done the comparison because of the shortage of time.
Ah.
I couldn't put it up, but sir, naive Bayes classification, there are independence. I mean, there is while selection there is independence. So multiple decision trees are not drawn, but only single decision tree is drawn.
Okay.
So for that, due to that, random forest classification is more favorable than the naive Bayes classification.
Okay, that's so when you are concluding one statement,
Yes.
so you should show something in the result section.
Okay.
So otherwise you cannot conclude it at a conclusion.
Okay.
So, how do you apply this? What is the usefulness of this study?
So usefulness of this study is, sir, if like hard exudate, cottonwool spots, and ARM like dry and wet ARMD, if the appearance-based features are applied, like color, size, the sharpness of the edge are applied, then we can extract some clue, and from there, from the output image, when the region-based features are applied, like sharpness, eccentricity, convexity, then we can derive the exact disease and classification of the disease, because we are here classifying only diabetic retinopathy and ARMD. Thank you, sir.
Good afternoon, respected judges. So I'll be presenting my work on systemic evaluation in patients with central serous choroidopathy, a prospective case control study. Central serous chorioretinopathy is a pachychoroid disorder, and the pathogenesis and treatment of CSCR is very ambiguous. What is the most accepted hypothesis that it occurs because of increased hydrostatic pressure and hyperpermeability of the choroidal vasculature that leads to the breakdown of the overlying RP barrier. Now, various studies have been done in the past to evaluate the systemic risk factors for CSCR, but the lacunae in these studies is that majority of these studies are retrospective in nature, depending on the historical data, or they have smaller sample size and lack case controls. So we took a study with an aim and objective of assessing the systemic profile of patients with CSCR compared to controls, not just based on the historical data, but also supported by clinical and biochemical evaluation. It was a case control study, and it recruited 87 cases of acute or chronic CSC with no other ocular pathology, and 82 controls with patients with primary non-traumatic rhegmatogenous retinal detachment with no history of ocular steroid use, just so that we have a matching control group with visual loss visual loss present in both the groups, as visual loss can be a stressful incident and can lead to a different biochemical profile in the patients. A detailed ophthalmic and systemic history was taken, and detailed biochemical investigations were performed. Sleep apnea was also evaluated in these patients using a Berlin questionnaire, which is a validated questionnaire for obstructive sleep apnea. Appropriate statistical tests were performed, and univariate and stepwise multivariable analysis was performed to identify the risk factors for CSC. So coming to the results, in the history-based clinical features, alcohol use, sleep disturbance, gastroesophageal reflux, psychological disorders, and history of tuberculosis were found to be significant in univariate analysis. Use of systemic steroids and obstructive sleep apnea risk was not significant different. In the biochemical assessment, we found that the cases had better hemoglobin levels, higher systolic as well as diastolic blood pressures, and lower T3 and TSH levels as compared to the controls. When we compared the thyroid state between the two groups, it was found that the significantly more patients had a dysthyroid state as compared to controls. On performing a logistic regression of now the factors which were significant in univariate analysis, we only found that alcohol use, sleep disturbances, self-reported sleep disturbances, and dysthyroid state on biochemical evaluation were the significant risk factors. So coming to the discussion, it may be that the idiopathic CSC, which is unrelated to exogenous steroid use, the treatable medical and social factors are more important here. Like we found that alcohol use, sleep disturbance, and dysthyroid state were significant factors in our study. In a recent meta-analysis which has been done, it has been found that in Asian population, steroid use is not a significant risk factor. Now, this is exogenous steroid use we are talking about, but it could be that endogenous cortisolism is there in such patients, and previously studies have pointed out that not only an elevated 8 AM serum cortisol, but it could be a diurnal fluctuation that is more important in these patients, and overall 24-hour cortisol levels may be high. Now coming to the thyroid hormones. Now thyroid hormones, it is in the previous literature, it has not been evaluated thoroughly, but thyroid hormones increase the metabolic clearance of cortisol, and they also modulate the adrenal receptors. Therefore, they may have a role in the pathogenesis of CSCR. And in our patients, we had T3 and TSH levels low in our cases as compared to controls, suggesting a central hypothyroidism and maybe a hypothalamus pituitary axis dysregulation. So the limitation of the study is that the serum and urine catecholamine levels were not tested, and as I pointed out, only morning 8 AM serum cortisol levels were tested, and sleep apnea was not further evaluated using polysomnography. To conclude, this study reports possible association with deranged thyroid hormones, and it paves the way for future research into role of choroidal imaging in hypothyroidism and effect of thyroxine supplementation for treatment of CSCR. Thank you. These are my references.
How many cases?
87 cases were included and 82 controls.
Questions?
Why you have compared the CSR case with retinal detachment?
So because visual loss is itself is a stressful incident. So if it is already normal patient group which doesn't have a visual loss, then comparison because if we take healthy controls, they'll not have any stressful incident. And
age matched controls also.
we took age matched controls